Alright, there's several keys to performing an efficient lumbar exam, and today is the main focus of it is efficiency. So there's certain tests that you might have learned in school that I'm not going to show you today. You can incorporate those into the exam if you'd like, but this is some of the key things that will allow you to pick up some of the most important or primary impairments in your patients. So one of the biggest things to start off with is that you want to have as few positional changes as possible. And by that I mean he's starting and sitting during the subjective interview, and we want to go from sitting to standing, supine to prone. A lot of times in school you learn tests for the SI that are in supine, prone, and standing, and you end up moving the patient back and forth 5 or 6 times, causing them more pain. So the big focus with the efficiency is keeping them very systematic from one position to the next. So going through an efficient lumbar exam, first you're there in sitting because of the subjective interview. So for the first 5 or 10 minutes you're asking them questions and they're already in the sitting position. So before you get them into standing, let's do a few things in sitting right now. If they report any sort of radicular symptoms or any symptoms going down the legs, you want to perform a slump test. To perform the slump test, bring your popliteal fossa back against the back of the table, draw the knees together, and then bring your hands behind your back. So first thing, slump down, block the head, and then slowly bring the leg out. And through each phase, you want to ask them, are your symptoms better, worse, or the same? So are they having a change in symptoms by bringing the leg out? And then if so, raise your head up. And then by moving a distant component, does that change the symptoms at all? So in sitting, we're going to perform a slump test first. And then also, since it's a low back exam, a lot of times the nervous system is involved. Next, you can, if they're reporting any weakness in the lower extremities, you can do dermatomes, myotomes, and reflex testing as well. Also, you can choose to perform Clonus and Babinski testing. I'm not going to review all those today, but those are options if the patient is reporting lower extremity numbness and tingling or gross weakness of the lower extremities. Alright, stand up for me. So again, as few positional changes as possible. We go from a sitting position, and we're going to do several things in standing right now. So standing, I always start off with function. First, I want to watch the patient walk, then we're going to do a squat, followed by single leg balance. So, walk across the gym for me. Good, come on back. Perfect, stop there, face that way. So gait, everyone has their different way of measuring gait. I generally, since we're working on the low back, look at the low back and the hip region first, and then we'll work my way down the lower extremities. So in the back and the hips, I'm looking as they're accepting weight through one leg, do they have a Trendelenburg? Is the belly button moving straight ahead, or is it going back and forth as they're walking? So some of the key things I look for right there. Next, I'm going to have you squat down. And come back up. I often have them perform 2 or 3 squats. One I'm looking from the front, one from the side, and then one from the back. From the front angle, squat down again. I'm looking at the position of the knees relative to the foot and ankle and the low back. So are they caving in here? A sign often of posterior gluteus medius weakness. Also, are they adducting or are they both internally rotating and adducting? Different things that you should be looking for. Go down one more time. The other thing I really look for on the squat is the position of their core and also the position of their tibias. Are they moving forward a lot? What I call a quad dominant gait pattern or a squat pattern, and then also come back up. The position of the low back as they go down, do they arch their back a lot to get up? So people will often say squatting is difficult, but it's really as they're ascending, they hyperextend their low back, overuse their paraspinals because they're avoiding using the gluteal muscles. So we've done gait, squat, and finally single leg balance. So have them bring one leg up. I try to go to about 90 degrees. And I want him to hold this for 5 or 10 seconds or as long as he can. Perfect. Switch sides. And again, a lot of people directly out of school, they think about single leg balance only as a balance component. what you should be looking for, similar to the squat, is how are they accepting weight through the leg? Are they doing a Trendelenburg? Is the lower extremity shifting a lot? Do they have good support from their ankle? So there's several pieces of information that you can gain from this assessment here. All right, so we've done a few functional things. Let's check out his cardinal plane motion, his lumbar active range of motion. Okay, feet together. One of the things that I am really key on is consistency from the start of the test. So feet are always together to start. That way it's very reproducible. Feet together. First flexion. Go forward as far as you can. Touch your toes. As they flex forward, what I'm looking for is a uniform spinal curve. Do his hips translate posteriorly? And then also the angle of his sacrum. So I want about a 70 degree angle at his sacrum. And as you can see, he gets a lot of thoracic kyphosis and kind of flat from the lumbar spine. So I'd like to see more of a curve all throughout the spine. Come on back up. Next, hands on your hips. Extend all the way back. And the big thing I'm looking for here is are the shoulders symmetrical? And then is he hinging from his low back? So I always lift up the shirt in this one. And I'm looking for a hinge point in the spine. Or does he have a uniform spinal curve there as well? We'll go right arm down past the right knee for side bending. Good. Come on back up. And the other way. And the big thing that I'm looking for with lumbar side bending is symmetry side to side, and then also their pain response. And finally, rotation. Good, so I start off with whole body rotation. Go the other way as well. I get a general sense of, are they moving more from their hips or their low back? Then I'll come in and block the hips, and I'll have you go to the right again. Good, and then to the left. Thanks. Again, symmetry side to side, and then also, is there a change when they're doing their whole body motion versus just the low back movement? So, you can also do some functional instability tests that we've talked about in a previous video, but next let's go down to the table and into supine. Okay. So, a few positional changes. We've done all of our sitting stuff, all of our standing. Now we're going to do a few tests in supine. Big things are, is it a low back patient, is it a hip patient, or is it an SI patient? So first thing I always do as they're in supine, I'm just going to have them bring the leg up. I want to check both involved and uninvolved side. So let's bring your leg up. Good. Knee motion's fine, it's just a very quick assessment. Let's check hip mobility. Good, his hips are actually moving pretty well. And then can you pump your ankles up and down? Good. Very quick screening of the lower extremities. You have ankle, knee, and hip all pretty much cleared there. If I would be moving his hip into internal rotation, he's like, that's my pain again, then I would definitely want to investigate the hip a little bit more. So we've cleared the lower extremities. Let's do a few SI tests as well. You can do your distraction test here. I do it in supine, you can also do it in sideline. Then your compression right through the SI, or right through the ASISs. And you're looking for reproduction on those tests of their SI joint pain. Okay, if they report pain way up in the low back or on the ASISs, that's not positive tests. In supine also, we'll do a straight leg raise on both sides. Again, looking at core stability, you can get a lot of information from the straight leg raise. So if I'm looking at it for core stability, I'm looking to see if the pelvis rotates at all. But then also, as we know, the straight leg raise and cross straight leg raise are very sensitive for disc herniations. So raise this leg all the way up. Good. And so if he would have pain between 30 and 70, and it would be reproducing some of his neural symptoms, you might think more neurogenic. But in his case, if he's more someone who, I'm thinking hypermobility, I would be looking to see if he's having any shifting from his pelvis. So those are the big things that I do in supine. Finally, roll over for me. Final position here, what I'm really looking for in prone is you can assess glute strength, and I'm looking at lumbar and thoracic mobility. So slide over towards me just a little bit more. First, pressing, finding your bearings, iliac crest L4, L5. press down through L5, work your way up through each one, and you're looking for pain provocation and then also mobility. So Dane is moving fine through his lumbar spine, and then I'll do a gross thoracic mobility assessment as well. And as I expected, based on his squat and a few of his other functional movements, he's not moving quite properly through here. So joint mobility is huge on your prone examination. Finally, I like to check out his glute strength. As you're assessing glute strength, as I've talked about in a previous post on hamstring dominance or lumbar paraspinal dominance, as he's holding that leg up, you want to make sure that he's using his glutes to hold him up and not his low back or his hamstring. So, okay, relax for me. And then hold right there. So when they're holding here, is he using this muscle or is he using the muscles above and below to stabilize that? So press down. Yeah. And he's fine on glute strength. Those are some of the key things that I look for, as I've said multiple times throughout the video. Few positional changes. People are going to come in with a lot of pain, and by moving them around, you're going to confound your own test results by having them go 5 or 6 times from sitting to standing, for example. Other things I would say to look for most importantly, is that in your examination, find some primary impairments, things that you know you can change. Make one of those your asterisk sign, and then see if you can change that within session. Another thing I didn't talk about today is repeated movements. I often incorporate repeated, actually any position, side bending, flexion, extension, to see how doing repeated loading into one position changes the patient's pain. So check out more videos from the student physical therapist. If you have any more questions, send us an email.